Hello, this is Dr. Bernstein with our November 2016 Teleseminar. Before we start, I want to give you the usual warning that my answers to questions are opinions based upon limited information. It's not really good medicine to make a diagnosis or give advice without examining and getting a full medical history. But the purpose of this teleseminar is for the audience at large, not for the people who ask the individual questions. So there's a very good chance that my answer to your question may not be the correct answer. Our next teleseminar will be on Wednesday, December 28th, 2016. The special subject for today is personal opinion. A diabetes cure is getting closer, but the big money is misdirected. Now, what prompted me to pick this subject was an article in the journal Nature on October 17th, 2016. Nature is a very learned scientific journal which carries latest research. And in this journal, investigators took cells from the tip of the tail of mice, or tails of mice, and were able to treat them so that they became oocytes, or ovarian egg cells. This is quite an accomplishment. To transform tail cells to egg cells was unbelievable, let's say, a few years ago. And we do know that many investigators around the world are converting human cells to beta cells that make insulin. So they're converting the cells that line the ducts in the pancreas to beta cells. They have new evidence that the alpha cells that make glucagon, which are not destroyed in diabetes, are also stem cells for beta cells. So things are getting very close. I'm utterly astounded by this research on mouse tail cells. And if that can be done, there could well be a biologic cure for diabetes on the horizon. By biologic, I mean one that uses living cells in the solution. Now, unfortunately, the big money is going elsewhere. You may have read about several drug companies, big drug companies, largest drug companies, teaming up with information technology companies to seek a cure using mechanical means, like the so-called artificial pancreas, that can't possibly work because they're giving people high carbohydrate diets, and we can't do that with mechanical devices. Insulin doesn't work instantly. There are all kinds of assumptions that are invalid. So the money currently the big money is going into mechanical artificial pancreas, whereas it should be going into a biologic solution, such as the mouse tail to oocyte research. But we'll see what happens. Maybe someone of influence will listen to this broadcast and do something about it. Now we'll start the questions. The first question asks for details on my mixture of DMSO and lavender oil for treating a variety of localized pain syndromes and which don't necessarily just apply to diabetes, but could apply to many things. For example, I mentioned the arthritis at the base of my thumb from squeezing the other hand for finger sticks. I've done probably more finger sticks than anyone else in the world, going back to 1969. In any event, and I also should mention that I tried this on a friend in the gym who had chronic back pain. He was told that he needed surgery. We put some on the area of pain, and it's been 2 weeks, and he still has not had a recurrence of pain. That doesn't mean that the treatment is going to last forever, but maybe he'll need to do it every few weeks. In any event, the formula that I use is 99% DMSO, which you can get from a compounding chemist or a veterinarian, and we have 16 parts of DMSO to 1 part of Camille, Camille, brand of lavender oil. The ratio is important because if it's too concentrated, the lavender oil can irritate the skin. We use Camille brand not because it works better, but because it smells better. Most commercial lavender oils that you can get on the internet have an unpleasant aroma, whereas Camille smells great. We put it in a roller bottle or a roller cap bottle like deodorants use. It's a small ball about 3/4 of an inch in diameter. It can be plastic, it can be metal, it doesn't matter. I've stored this stuff at room temperature. It doesn't seem to deteriorate. Although the bottles I received are brown, it probably would work in a clear bottle also. And that's about all I can tell you. You roll it on at the point of pain, if it's a point, but also all around it. If it's at a joint, you want to do the side of the joint that is painful, but also the reverse side. So if I had pain over here, I'd also do it on the reverse of the thumb. Next question. I have had type 1 diabetes since 1987. It wasn't until I was on the insulin pump for 2 years that I suddenly developed an allergy to insulin. And then the person asks, what do you do about insulin allergies? Well, first of all, there's a question as to whether the allergy is something that gives you difficulty breathing, getting swollen, or just local irritation, or just severe insulin resistance. Now, both situations can be treated via a classic method of increasing concentration. What you do, and I've done this for people who are insulin resistant. I had a type 1 diabetic who was in her teens and required several hundred units of insulin, and we did the following. I mixed a dilution of insulin where the concentration was 1 in 1,000. What I did was I got diluting fluid, which you can get from insulin manufacturers. You can only get it for regular insulin, Humalog, Novolog, and NPH. And since human insulin is regular, I would choose to initially use diluted regular insulin. So we take regular insulin, which would be Humulin R or Novolin R, and we mix it with 999 parts of diluting fluid. So this requires a lot of diluting fluid and a little bit of insulin. And you don't have to be absolutely precise. So you could measure 1 unit of insulin out of an insulin syringe and squirt it in a bottle that contains 1,000 units of diluting fluid. Now, 1,000 units would be about 10 cc. No, let's think. 1 cc is 100 units. Yeah, 10 cc's. So you have a 10 cc vial of diluting fluid, and that's how they supply it, by the way. And you can get it for free from, as I said, from the insulin makers. Put in 1 unit of insulin into the vial, shake it up, and then inject with a long needle, that is the 12.7 millimeter needle, into the forearm. But it has to be subdermal, or intradermal as they call it, not subcutaneous. So a doctor should be doing this. He should know how to give an intradermal injection. Now, because most doctors are not taught hands-on care in medical schools, you probably should not be using a young doctor to do this, at least if you're in the USA. The older doctors may still remember how to give an intradermal injection. It would be in the forearm on the side of the arm where the palm of the hand is located. And it's barely below the skin. The needle goes almost parallel to the surface of the forearm to give the injection. And you give this shot, chances are the patient will not get a reaction to that small dilution. And you wait an hour, and then you give another intradermal shot at maybe 10 times the concentration. In other words, 1 part in 100. So you take an empty vial, squirt in 100 units of diluting fluid, and squirt in 1 unit of insulin. Sort of shake it to mix it up, and you inject it the same way. Some people might want to wait 2 hours. Depends on how much of a hurry you're in. But I did this, it took me a number of hours. So now it's 1 part in 100. The next time you do it, you might, an hour later, maybe 2 hours later, you might want to do 1 part in 20. So you inject 20 units into an empty vial, and then you inject 1 unit of insulin. And again, you draw out 1 unit in a syringe. If it's a small person, you might draw out only a half a unit for each of these intradermal injections. And you could go from one arm to the other arm. You don't have to do them all in the same arm. But it's a wise idea to circle the injection site with a felt tip marker so that you could look to see if there's any inflammation. If there is inflammation, you may want to then give the next shot at half the concentration that I would ordinarily recommend the next shot. So here we've gone from a 1 part in 1,000 to 1 part in 100 to 1 part in 20. If there was a little inflammation, you might want to give 1 part in 40. And you keep playing this game until you inject 1 unit or a half a unit of pure human insulin, Humulin R or Novolin R. And that should accomplish the job. That's the classic way of desensitizing to a host of substances, and in this case, insulin. I am a type 2 diabetic and control my blood sugar with diet and exercise. I follow the low carbohydrate, high fat diet. Again, that's not what I recommend. I recommend low carbohydrate, high protein, and then as much fat as happens to come along with the protein. I experience regularly the dawn phenomenon. When I wake, my blood sugar is roughly 33% higher than it is 4 hours later in mid-morning. What foods, if any, can I eat to deal with this? Well, if your blood sugar, this has nothing to do with food. It has to do with the fasting state. If you awaken with a blood sugar that's higher than it is later on, you probably need medication. And you want medication that's working from about 4 or 5 hours before you awaken until several hours after you awaken. Now, there are a number of options. My preferences would be glucophage XR, timed release glucophage, not metformin, because metformin is not as effective. That's generic metformin is not as effective as the brand glucophage. So at bedtime, you would take glucophage, and the dose starts at 500 units and can be increased all the way up to 2,000 units. You start low and see what it takes, and if it works. Another medication that I would consider would be Avandia, which you could use instead of the glucophage if you happen to get diarrhea from glucophage. And of course, insulin always works. So you can always take a small dose of Tresiba insulin at bedtime. But read my book, Diabetes Solution, because it gives you all these ideas and tells you how to titre medication doses. What is your opinion of the following statement? Researchers suspect that taking statins impairs the function of special cells in the pancreas that store and release insulin. There is also evidence that statins can decrease the body's sensitivity to insulin. Well, we do know that statins increase the incidence of type 2 diabetes. I believe the latest report was that 20% of non-diabetic statin users develop type 2 diabetes. So that would suggest that indeed statins affect the body's production of insulin. So I have to agree that the literature supports this. It doesn't happen to everybody. It only happens to 20% of the statin users. And that's about all I can say. What is your profession for orthotics? Firm foam, soft foam, hard plastic. My personal preference is firm foam. But there is a company that makes a computer customized hard plastic orthotic that's actually milled out of hard plastic. But I think let's see, I forgot the name of the company. It may be Trueform, but the problem with soft foam is that it collapses under the weight of the user, and in relatively short order is of no value. The firm plastic tends to last a long time, although I found that for very heavy people, the firm plastic may flatten out in a few months, let's say 4 months or so. And as I said, the big problem with the hard plastic is that they're usually not adequately customized or posted. The typical situation is a podiatrist or pedorthic footwear specialist takes a foam imprint of your foot, sends it to a company that then takes a hard plastic insole off the shelf to most closely match your foot, and then your provider may or may not put additional padding under or over the plastic to customize it. Usually the provider does not give the customization, whereas if you're using a soft foam insert, it's more common and easier to put padding underneath the orthotic. It'll be more effective under a soft foam than under hard plastic. The subject is pretty complex. Maybe one day we'll do some video where I put padding under orthotics. The process is called posting. You could look up on the internet posting an orthotic, and there might be some instructions there. I've been diagnosed as being severely vitamin D deficient. Please address this problem and the ramifications regarding an elderly type 1 diabetic. Well, vitamin D deficiency should be corrected for everybody, not just diabetics. This is not a unique problem to diabetes. At one point, it was thought that vitamin D deficiency was a cause of type 2 diabetes. That's been disproven, but it does appear that many type 2 diabetics do have vitamin D deficiencies, but also in the northern hemisphere, and I guess in the far southern hemisphere, most people are vitamin D deficient. It's in the equatorial areas where they get exposed to the sun that they're not vitamin D deficient. And vitamin D plays a role in many systems throughout the body, and it is a good idea to take supplementation to the point of getting your serum vitamin D3 level in the middle of the normal range. Now, the normal range is questionable because different doctors have different opinions as to what's normal. I try to get my patients a value in the units used in the USA of between 50 and 90. And it's interesting that different people require different degrees of supplementation over a wide range. Some people get into the normal range with 500 IU per day, that's international units. Others need as much as 10,000 IU per day. What determines this, I don't know, but it's trial and error. My endo says that your diet can cause my low testosterone levels and nearly absent free T3 and elevated cortisol. Your comments? Well, I've never seen this. I've not seen any changes in testosterone and cortisol levels, but we do know that a low carbohydrate diet can lower free T3. It can affect the enzyme that causes the deiodination of T4 to T3. Now, that doesn't mean it will cause an abnormally low free T3, but it can lower free T3 somewhat. How many times per day should I check my blood sugar? Well, first of all, do you have diabetes? If you don't have diabetes, why are you checking your blood sugar? If you do have diabetes, the first thing to do is to read my book, Diabetes Solution. It'll tell you when to check your blood sugars if you're going to do something about them. If you're not going to do anything about your blood sugars, why test them? And this is a strange current phenomenon. Doctors have patients checking their blood sugars. The patient looks at their blood sugar, gets upset. The doctor doesn't even see their blood sugars, and no one does anything about it. That's why I wrote the book. So if you're going to do something about it, it depends what you're going to do and when. Now, with a total type 1 like me, before I started getting gamma globulin, which forces me to check my blood sugars very often, I would check on a rising before each meal, including breakfast, and before the next meal. But if I'm breaking in a new patient and we don't know what's happening in between meals, are they going too low? Are they going up and then down? I would have them check maybe 1 and 2 hours after each meal in addition to before the next meal. So it all in these situations, if you get abnormal blood sugars, we expect an intervention. The intervention may be changing the timing of the prior meal. It may be changing the nature of the insulin that we take for the prior meal. We might mix a tad of NPH with regular to slow down the regular, or if you have gastroparesis. So there are many reasons to check at different times, and that's why you should read the book. I am a pre-diabetic with an A1C of 6.0. Well, that's an average blood sugar of 140, which means this person's blood sugar may be jumping up to 180 and going down to 90. We have no idea what's happening over the course of typical days. I would call that person diabetic, even though the ADA would not. I just started following your diet and I feel more tired. I think the fruits gave me more energy. Stopped all fruits. Your thoughts? Well, first of all, I would check my blood sugar when I feel tired, because we frequently find that when blood sugar is lowered from a high value to a less high value, people feel hypoglycemic. And one of the signs of hypoglycemia is fatigue. Now, I've found much more drop in blood sugar from diet than from any of the oral agents. So a person may be walking around, and literally, and also A1C. So we've seen people with A1Cs of 11 come down to an A1C of 7 just by a low carbohydrate diet. And then it takes medications to do the rest of the job to get them down to say 4.2 to 4.6. So just a big drop in average blood sugar can make you feel as if you're hypoglycemic, even though you're really not. And this is to be expected, and it's the reason why in my book I warn people that you may have to lower your target slowly rather than rapidly because you'll feel uncomfortable. So check your blood sugars, see if your blood sugar is how much of a drop you've had between the time you feel tired and you don't feel tired, and read my book. I have been a diet-controlled diabetic for years, but had been stable to say under 7 A1C. At 6.8, I decided to try metformin. My fasting blood sugar went from 156 to 146. That's a small drop. But it made me very hungry, and I gained 10 pounds and went back to 156. My endocrinologist told me to stop the metformin. Now my fasting sugar is 170 to 200. How could this be? Well, I'd have to see much tighter details of your history. But one problem that I see from the very beginning is that you are using metformin instead of glucophage. And as I've said over and over, generic metformin is not nearly as effective as glucophage, and there may be some generic brands that are totally worthless. So to see a blood sugar go up with metformin, generic metformin, is not a great surprise to me. I suggest, number one, that you read my book, Diabetes Solution, and number two, that you try glucophage, and you may need some other medication. And as I say over and over, insulin always works. What are your thoughts on the use of Invokana and its long-term effects on the kidneys? I have noticed my blood work that my blood creatinine has gone from 1.1 to 1.3. My doctor says not to be concerned, and this is normal. Well, I consider, if it were me, I would be concerned. I'd be worried. However, we know that Invokana causes dehydration if you are not adequately hydrated. You have to drink much more water when you're taking Invokana than when you're not. How much depends on the individual, but I will see people whose creatinine goes up and whose hematocrit goes up, and a high hematocrit, that is a larger percentage of the blood being red blood cells, reflects less water in the blood. So we have seen this with users of Invokana, and this is a problem. You have to be adequately hydrated, or you're going to have a variety of problems. An elevated hematocrit can cause problems. You could have abnormal serum sodium and chloride levels by taking Invokana, and you have to very deliberately be consuming a lot of fluid. And dehydration will cause your serum creatinine to go up. So it may just be because you're dehydrated, but that should be corrected. It's one reason why I use Invokana only as a last resort. For example, I have one patient who had at one point tried Invokana, and his blood sugars showed a dramatic improvement. much more than we usually would see from Invokana. So I let him continue, but I tried to make sure that he was drinking enough fluid. Other situations where I might use Invokana might be where a patient absolutely refuses to take insulin, and a combination of other medications gets his blood sugars almost normal, and we'll try Invokana to see if adding that really gets him into the normal range all day long. And if it does, we'll use it. But this is a very rare situation. I would much rather use insulin than Invokana. Your thoughts on Trulicity. Trulicity, and I've discussed this in other teleseminars, Trulicity is a GLP-1 agonist that supposedly works continually for a week. Now, I only use GLP-1 agonists to control appetite. Their effect on blood sugar and A1C is very small. Depending upon the study that you look at, it might affect A1C from 0.1% to 0.3%, which is very little effect upon blood sugar. But it can affect carbohydrate craving tremendously, and for some individuals. So if you're going to use it to curb carbohydrate craving, you use it at the time of the day when they have the most craving. Now, the most common time of the day is between supper and bedtime. Therefore, you want a relatively short-acting GLP-1 agonist that you might take before supper, hoping that it'll work starting an hour after supper. So that might be Byetta. It might be I forgot the name of the one that mimics what the pancreas makes. Something like Victoza might be a little too long-acting unless you stay up very late at night. If your supper is at 6 and you stay up until 1 a.m., you might use Victoza because it lasts for a number of hours, for many hours. But to take something that's going to last for a week is wasting its effect on many, many hours when you don't need it. And one big problem with the GLP-1 agonists used for curbing cravings is that they frequently wear off. And the more you give, or the longer you give it, the more the likelihood of it wearing off. So if you're giving it 24 hours a day, every day of the week, it's going to wear off sooner than if you just give it for 4 to 6 hours at night. Let's see. What are your thoughts on the news today from Medtronic regarding the approval of the closed-loop insulin pump? Do you think this system will be able to keep blood sugars in tight enough range? Absolutely not. The whole concept of insulin pumps is a myth. The myth is that you set it for certain basal doses, which is reasonable, but then that you guess at the amount of carbohydrate that you're going to get in a meal and set a bolus to cover that amount of carbohydrate, and that you can change the amount of carbohydrate from one meal to the next, from one day to the next, and so on. And basically, it's telling you to guess at a dose and hope that it works. And that's asking for trouble. On top of that, it's only looking at carbohydrate, where if you read my book, you'll know that protein also affects blood sugar, and that the mass or bulk of the food affects blood sugar. So you can eat a non-food and raise your blood sugar. For example, a type 1 diabetic can eat a handful of pebbles and his blood sugar will go up when it distends the gut. So the whole concept is based on dietary myths, but there are other myths and there are other problems. For example, the fact that eventually you develop scar tissue around the infusion site, and that makes the absorption of insulin unpredictable. So here you have something that's guaranteed not to work, and yet it gets approved by the FDA as if it's going to be a magical solution. Next question. I'm an LADA, that's latent autoimmune diabetes. This is a very rare condition that sometimes involves very large doses or high resistance to insulin and requires large doses of replacement insulin. Many, many people are diagnosed with LADA who are just simply type 1s. The diagnosis has been generally frivolous. That is, most people with that diagnosis don't have it. Diagnosis 2011 at the age of 42. I am currently using an insulin pump with your regimen. Well, if you're using an insulin pump, you're clearly not using my regimen. And let's see what's happening. Achieving 4.8 to 5.2 A1Cs. Well, that's pretty amazing. I just convinced my endo to prescribe regular insulin and Tresiba. My question is, does your regimen for Levemir apply to the Tresiba? Well, it does approximately. That is, in the book, when I wrote the book, Tresiba existed, but Levemir didn't. I'm sorry, just the opposite. In my book, Levemir existed, but Tresiba did not. Tresiba lasts longer and is better able to cope with the dawn phenomenon if you take it twice a day. Levemir, when taken twice a day, usually does not last overnight long enough to cover the dawn phenomenon. So what I usually do when I switch a person from Levemir to Tresiba is, in my head I'm thinking they may need the same dose of Tresiba as Levemir, maybe even a little more insulin because Tresiba is spread over more time, but I'll start them with 1 unit less. So if they're getting, let's say, 6 units of Levemir on arising and at bedtime, I might start them with 5 units of Tresiba arising and bedtime. Look at fasting blood sugars, that is, what happens during the day if you don't eat all day, what happens overnight where you're not eating, and I might raise the Tresiba dose because blood sugars go up. Or, to my surprise, they might go down and I might lower the Tresiba dose, but it's trial and error. So I usually start at about 1 unit less twice a day, less than the Levemir, and then up it based on what blood sugar information I get. Why measure glucose at 2 hours instead of 1 hour post meals? Well, first of all, it depends on whether you're taking insulin or not, and it depends on what you're going to do about your blood sugar. Now, I do this initially on new patients, whether they're taking insulin or not, to get information. I want to see, do they go up after meals? Do they stay up? Do they go up and then go down? So this is a must for a new patient where I'm just gathering information. Once a person is stable, it may not be necessary to check in between meals at all, except immediately prior to the next meal. So if you're on a regimen where everything is working and your blood sugars are flat in between meals, there's no sense in checking 1 and 2 hours after. Whereas if you have gastroparesis, on the other hand, which may be very unpredictable, and your stomach empties differently every day, you may need to check it 1 and 2 hours after just to avoid hypoglycemia. And it all depends. It's not that there's a hard rule of checking 1 hour or 2 hours. It depends on the situation and what you're looking for. Again, read my book, Diabetes Solution. Do we yet know what causes atherosclerosis? Well, for diabetics, we know that elevated blood sugar causes atherosclerosis. We also know that in non-diabetics, even tooth infections can cause atherosclerosis. The one thing that we know is incorrect is that moderately high cholesterol is not a significant risk factor. There are people with familial dyslipidemias who have very high cholesterol or very high triglycerides. Those are unique situations. But if you're diabetic, the main thing is to normalize blood sugars. Top endocrinologists in my state believe all diabetics over the age of 45 should be on statins. Is there a definitive study or two that I can show them to change their minds? Well, a report, I should say a whole series of studies came out in a special issue of the Journal of the American Medical Association on November 15th, 2015. It's about statins. And it points out that the evidence supporting the use of statins is questionable, but the recommendations of the AMA are still that people over the age of 45 well, let me retract. They talk about primary care or primary use and secondary use. Primary use is for people who show no evidence of heart disease, and the evidence for that is certainly lacking, and this issue makes that clear. The secondary application of statins applies to people who are at high risk. And indeed, people with uncontrolled diabetes are at high risk for heart disease, and the statins may be of value. In fact, if you do a search on the internet for articles on this subject, look up how many people must be treated for 5 years in order to save one life. And for secondary use, I believe the numbers you see will range from something like 48 to 111 people have to be treated to save one life. And that kind of evidence should be seen by your physician. But you should also show him this current issue or recent issue of Journal of the American Medical Association and remind him that, yes, diabetics are considered high risk and therefore secondary prevention. But what about those with normal blood sugars who have had normal blood sugars since the start of their diabetes? That's another story altogether. And these people should not be in the secondary prevention category. I don't think I should be in the secondary prevention category. I had a coronary artery calcium score study several years ago, and which, the score can go anywhere from 0 to 15,000, and I had a score of 1. Now, I've had diabetes for, I think, 71 years, and the early years I was very poorly controlled. But by doing the right things, read my book, I reversed that situation. So I certainly don't think that I qualify for secondary use of statins. So here we have primary use is very questionable, and you read this JAMA issue. Secondary use can be of value, but you have to treat many patients to save one life. So you can show this issue to your doctor, and if your blood sugars have been essentially normal since the beginning of your diabetes, you may not qualify for secondary application. One thing you can do is get a coronary artery calcium score and a few other related studies to prove that it doesn't apply to you. Okay, we'll get on with yet another question. My question is regarding exercise and its effect on raising blood glucose and how high I should get and how quickly it should come down. Now, ordinarily, exercise should not raise blood sugar, but I'm reminded of the teaching of Elliot P. Jocelyn back when I was a kid, somewhere around 1947. And I went to his classes, and I only remember one thing that he taught us. He said, don't run a block for a bus. If you're going to run for a bus, run a mile. And the message was that there are stress hormones that we make when doing certain forms of exercise that can raise your blood sugar. And if you're not going to do intensive enough exercise to bring the blood sugar back down, like if you're going to run only a block for a bus and then stop, your blood sugar will go up and not come down. So that's one cause of exercise raising your blood sugar. Another cause is if you exercise during the hours of the dawn phenomenon. Now, if you're taking Tresiba insulin, you may not have this problem. But I have many people, both type 1s and type 2s, whose blood sugars go up when they exercise in the morning, but not when they exercise in the evening. I've had in the past week, however, 3 people who exercise in the evening and their blood sugars go up and then they come down later. And my guess is that they're just not exercising strenuously enough to keep their blood sugars down. And this is a matter of trial and error. When I exercise, I do what's called anaerobic muscle building exercise, where I use a moderately heavy weight and do it from 60 to 120 seconds, that is, until my muscles are so tired I can't move. Anaerobic exercise lowers blood sugar. When I get on the exercise bike, I will do it at a heart rate. I'll attempt to get my heart rate higher than my theoretical maximum. That will keep my blood sugar dropping for hours. So it very much depends on the type of exercise that you do. Again, read my book where this is discussed. Last year I was diagnosed with LADA, which we discussed before, A1C of 13. I'm now down to 5.5. I was undiagnosed with type 2 for 6 years. A few years ago I noticed that I developed carpal tunnel in my right hand and that my feet don't sweat. Well, these are complications of diabetes, of high blood sugars, which this person had. As I move my A1C lower against doctor's orders, is there a good chance my feet will recover and hands stop tingling, or do I have to just accept what is done, moisturize and move on? Lower blood sugars will reverse neuropathies. That's the feet problem. They will not reverse carpal tunnel syndrome, which is due to glycation of collagen in the collagen band that wraps around your wrist. I have a treatment for that, which involves a mixture of DMSO and collagenase. This has to be ordered by a physician from a compounding chemist. We have 8 parts of DMSO to 1 part of collagenase. The collagenase is very expensive. It's more costly than gold, and we put it in a bottle with a little brush, like nail polish bottle, and you brush it on the carpal band, which wraps around the wrist, and that over time will reduce the thickness of the band so that it stops pressing on the median nerve. Now, have I done this? I've started it on several patients. I haven't had enough time to see if it cures it. But I have seen a cure of Dupuytren's contractures, which is a similar situation that involves the flexor tendons of the hand. And we've had swellings of these tendons size of walnuts that we've brought down to normal. Let's see. What do you think about using GLP-1 receptor agonists in the treatment of type 1 diabetes? I use it only to treat overeating. The direct effect of these things on blood sugars is nil, or close to nothing. What is the role of SGLT2 inhibitors as a sole treatment for mild diabetes, with or without glucophage? That's stuff like Invokana, Farxiga, and again, these things have potential complications, must be taken with a lot of water. The doctor is obliged to do blood tests to make sure that you're not too dehydrated. And to me, it's just not worth the effort. And the effect is relatively small. They say once you start a vial or a pen of insulin, you can keep it at room temperature. What do you do to keep it as effective as possible? I keep them in the refrigerator, or since I get insulin vials for free, I'll keep them out at room temperature a few weeks and then throw them away. I will not keep them in a room with room temperature above 75 degrees Fahrenheit. I'm just trying to think what else. As far as the pens go, it all depends how fast you use them. If you're using 2 units a day, or let's say 4 units a day, and the pen has 300 units, you got 75 days, you better keep it in the refrigerator. If you're taking 30 units a day, it's only going to last 10 days, you don't have to keep it in the refrigerator. So it's a matter of common sense. Well, thanks for listening to this teleseminar. I'll be with you again on Wednesday, December 28th, 2016. Good luck and have pleasant holidays.